So you can't understand that without putting it into that context. And then I think the last thing is to own that there are consequences to what we do and don't do. So when I was 25 and I had done this study in Oakland, and we had discovered in Richmond that 25% of the people were HIV infected, and in Richmond it was a third, and in East Palo Alto was a third, I had a choice. I could continue to do HIV research like almost every other person doing research with folks who inject drugs at that time, or I could try and step in and intervene. And I chose to intervene, and that's because there are consequences, right? So just studying stuff is not a valuable end in of itself. It just really isn't. I mean, I know we tell ourselves that in academia, and look, I'm as big a nerd about like just knowing stuff and learning stuff. I get that, I really like that. But, the truth is we use science for a purpose, right? And places like UC Santa Cruz that are research ones, there's whole efforts to commercialize the things that you discover. Like there's an agenda behind all of this stuff anyway. So my agenda is helping the people that I work with. And I'm very upfront about that. And I think it's important for more people to be like that. So I'll just self-disclose there. Okay, so let's go through this process. So what does the world look like if you're a person who injects drugs? Well, the first is, and you're all living through this, this sort of beginning of the opiate prescription, people call it an epidemic. There are a lot more opiates available, and that caught people up, right? And then we began acting on that opiate epidemic. So in 2010, we began restricting really seriously access to prescription opiates, which drove a fair number of people into heroin use. And then the illicit market responded to the fact that there were so many more heroin users by introducing synthetic opiates like fentanyl, which are much more potent, easy to traffic, and easier to get around the country. So that led to an escalation in overdose deaths. And now, using some of these same trafficking lanes, we've got the introduction of methamphetamines, and they've been around, but reintroduced. So like in my studies in Los Angeles, I went from 10 years ago having populations of people who really just use heroin and people who just use methamphetamines. And now, 80% of the people who use fentanyl or heroin also use methamphetamines. So we've sort of had this sort of doubling of the risk there. The other thing that's happened is hepatitis C has become a national problem in the United States. We don't talk about it enough. But we essentially went from having a single humped camel, where there were sort of people in my age cohort and older who were, potentially more likely to have hepatitis C, to this sort of two humped camel that includes younger folks like the folks in this room, and then again that older cohort of people. And that reflects that transition from prescription opiate misuse to heroin use. So when folks begin using heroin, it's much more efficient and cost effective to inject it than it is to use it through other means. And so that, and injection drug use is the main way that people get hepatitis C nowadays. We also have this growing bacterial infection crisis. So the one on your left is from Oregon, and just showing the sort of steep increases in hospitalizations due to bacterial infections most commonly associated with injection drug use, right? Your skin is your first line of defense. If you inject drugs, you're poking holes in your first line of defense. Plus, with an illicit drug supply, God only knows how that drug has been handled by the time it gets to you, right? So that's part of the explanation for that. And then the other one just looks at national data showing the same thing. So we've had basically a doubling in hospitalizations due to bacterial infections in a population of people who inject drugs. There's also now new HIV outbreaks that are happening, mostly associated with homelessness, and then also happening in novel places. So there County, Indiana, that resulted in about 200 new HIV infections in an 18-month period in like a rural county in Indiana. I think the county has 40,000 people in it. So in that 18-month period, there were 200 people that got HIV. So in Los Angeles, that has whatever, 13 to 16 million people. During that same period, we had 50 infections due to injection drug use. So, you have these sort of novel locations. There are outbreaks happening now in places like West Virginia, North Carolina, Northern Kentucky, Duluth, Minnesota. And that reflects, again, that spreading of HIV and then the spreading of injection drug use that complicates and increases your odds of getting HIV. The other thing that's happened, and I'll talk about this more, is that material conditions under which this behavior is occurring have worsened dramatically. And I'll get into that a bit later. But the point here is that more and more folks who find themselves with substance use disorder, regardless of what the substance is even, find themselves being unhoused, right? And in Los Angeles, where I live, being unhoused is a big problem. It actually isn't really that related to drug use. It's mostly related to our red hot housing market. But if you're a person who has a substance use disorder, you're not going to be as economically viable as other people, given the other rules we have in society, right? So we know, thanks to the war on drugs, you're less likely to have completed your education. You're more likely to have an arrest record. You're less likely to have social networks that have other people employed in it. And all of these things contribute to causing a negative outcome related to your capacity to stay housed. And then we have these other issues related to chronic dietary and health problems. We have the ongoing stigma against people who use substances. And it's really profound. I was actually talking to a friend of mine who's a documentary filmmaker, and he asked me if I was a good parent, to which I can make a case that I'm a good parent. I've certainly tried to be a very good parent. He said, well, you're a good parent if your kid isn't like a prostitute or a drug addict. And I was like, yeah, I don't think that's what's going on, right? There are lots of people who end up with substance use disorders. Sometimes their parents contribute to it, sometimes they don't. But I would contend that that's an indication of that stigma, right? That you sort of become some other kind of person than you were before. And that stigma is in and of itself harmful, right? So there are lots of people who end up not getting services because they've internalized those messages, right? And they've made what's a societal problem an individual problem that then they don't have the skill set or the capacity to overcome. Okay, so what I'm going to do here is compare the sort of scientific industrial complex approach to those 5 problems to the problems that the solutions that come to those problems when you engage with the population. So that'll be the comparison. So I'm trying to convince you that listening to people is a valuable way of helping them. Okay, so I'm going to draw on the outsiders, so NIH, CDC, researchers who do not use drugs, policymakers. And so here are the things that we've sort of come up with. Mostly they're biomedical interventions that are actually wildly effective. So as a sociologist, I could not be more impressed with my biomedical colleagues and their capacity to generate drugs that can actually address issues. When I started doing this work in '91, we didn't even have a test for hepatitis C. I think we discovered hepatitis C in '91, memory serves, so 89 around there. But in that time, we now have 8-week, one single pill a day treatments that cure hepatitis C. And it's a bit, the vaccine, the COVID vaccine is a great, the best example of that because we got that in 9 months, which is insane, but and an amazing accomplishment. But yet they're really good at doing this. So that's great. The problem is that we're not great at getting them to people. And so just as I made this point, when I started doing this work, HIV was a death sentence. It's now basically a chronic illness. When I first started doing this work, we didn't have prevention for HIV that was biomedical. We now do, pre-exposure and post-exposure prophylaxis is available. There are now going to be new preparations for the PrEP, the pre-exposure prophylaxis that allows for injection at either 1 or 3 or even 6 months. Fantastic. Really incredible accomplishments. We have good medications for opiate use disorder, so methadone and buprenorphine, less so naltrexone. But And then, of course, we have naloxone for reversal of overdoses. The problem is we're really bad at getting those medications to the people who need them because of an inadequate social structure and infrastructure around providing services to these populations because we've made them unhoused and driven them out of services, right? And so while these accomplishments are tremendous, they don't matter because the people who need them most don't get them. And it would have been better served if we had thought about in our design of medications for this population, authentically engaging with them in a way that we do for other groups, right? So how many different aspirins are there? How many different doses and preparations are there for birth control? How many different, if you're middle class and above, your access to all kinds of medication, allergy medications, there's everything. There's a dozen choices for everything, right? When we are providing services to this group, you can get buprenorphine basically in 3 sizes of doses, and because of the way it's paid for in California, you can only typically get it the sublingual way and not as a pill or injection. There are all these sort of restrictions on customer choice. Same thing with methadone, which we've known has worked since the late 60s. You can only get them in methadone in specialty clinics, right? That are mostly in urban minoritized communities. Right? So we have these medications, we just don't make them available to people. And one of the problems is that and this is a map of sort of funding from the Kaiser Family Foundation, is that we don't put money into preventing stuff, right? So we spend a fortune on treatments, which feed into our dysfunctional and profit-seeking healthcare system, but we don't put similar amounts of money into things like syringe services programs that would actually prevent people from getting HIV in the first place, right? Or into methods of dispensing these medications to people with substance use disorder so that they don't end up with chronic health problems. And so this has been true my whole career, that we've spent basically 2 to 3 times as much on even prevention research as we have on prevention services in the United States of America, right? And we have a better administration now, and they're using the term of harm reduction. I got a chance to be on a panel with the current ONDCP drug czar guy, and he seems like a good guy, but the money's not coming, right? They've made an investment of $30 million in harm reduction services, while they continue to spend millions and millions and millions trying to ineffectively interdict drugs coming across the border, right? Which has never worked. It just hasn't worked. So, or we continue to put people in jail for the drug use problems. All right, so you have these things that work, but they're not widely available. They're focused on individual behaviors and not the sort of context of the behavior, and they're not likely to result in us achieving the things that we want. So we have an alternative, and one of the things I really appreciate about Rupa's work is she's providing an alternative, right? And that's important because I think there's a truism about inequality, which is that, at least in this country, we really like to naturalize it. And so if we went through the history and you thought about the rationales that were offered for the enslavements of Africans or the taking of lands from Native Americans, there's a lot of work that goes into saying, well, we kind of have to do this, right? We're not bad, we're just doing the thing that makes sense, because God said so, or because we own this continent for some reason, or whatever the rationale is, or Black people deserve to be enslaved. I mean, that was literally the argument, right? We're doing them a favor. So it makes us not want to listen to the people who have problems, right? And some of that is also just a lack of self-reflection on those of us who've done well, right? I mean, I have a great story I could tell about how I'm a Superman. I don't know who my biological father is. My mom was 18 when she had me, right? But the truth is, all along the way in my life, people have stepped in and put me back on the right track, have lifted me up when I faltered. And I dare say they should have, right? That's what I do to the people in my lives. That's what we do as humans, right? We're in solidarity with each other, we help each other. And so we have to remember that folks who use drugs are in that group with us as well. And then that method always works, right? It doesn't always work at an individual level, but it certainly generates the kinds of outcomes where we don't have people living in the streets, or it could, right? And our, our comparator countries like in Europe don't have the same unhoused problem we do because they do sense that solidarity, right? There is an effort to build a social infrastructure that will lift people up. So when you engage with people who use drugs, you come up with great strategies that are practical, sustainable, and most importantly, effective. Most of these things are driven by this idea of harm reduction principles that have to do with being directed by clients, being practical, being non-judgmental, and being non-punitive. And as a parent, I've thought a lot about the punitive nature of our society. And the truth is, parenting styles certainly have evolved, right? So I got disciplined differently than my children got disciplined, for sure. But the truth is, any discipline that happened to me when I was growing up, or that happened with my children as they're now adults, was happening in the context of love and support, right? Like you can be corrected by people actually care about you. You might not like it, but they're not doing it because they're vengeful, hateful people. We have not created that condition in our society for disadvantaged groups, right? So they get punished disproportionately for relatively minor infractions, and then we're surprised they don't change their behavior. But every time you punish someone, you're reducing their capacity to act on themselves. You're breaking them down. Okay, and I'm going to show you with some data we have that really gets at this more profoundly. But before I do, let me just talk about a little bit more of these practical strategies that have come out of communities. Hold on, sorry. All right, so part of it is if you're in solidarity with people, then the problems become different. So when I first started doing my work, certainly HIV was a big problem. But the other thing that was a big problem was people kept getting arrested for syringes, right? And so in a situation where you have an infectious disease that's spread by people not having syringes, arresting people for syringes is great for the disease and bad for the people, right? So some of my earliest work was just documenting, yeah, we got to get police out of this business, right? We have to legalize syringes, right? And it seems counterintuitive, certainly from the AA and self-help environment. But the truth is, in my studies and other studies by other investigators, people weren't sharing syringes because they didn't know not to share syringes. They were sharing syringes because there weren't enough syringes. And so part of what syringe programs do is give you more syringes. And so we have to get police to stop doing that. The other thing we've sort of been able to demonstrate, and I'll go through these quickly, sorry. We'll make the slides available to you so you can look at them at your leisure, is that when you're more generous with people who are disadvantaged, they do better. That's right, right? Yeah, you can solve some problems with money, right? Right? Because that's what we do, that's what I do, right? If I have a problem and I have money, I use that money to solve the problem. So we can do the same thing with people who inject drugs. And in fact, I'm almost at the point, I don't know if I'll be able to pull this off, but I'd actually like to do a universal basic income experiment with people who use drugs. Because I think what it would show is that their drug use would more or less stay the same, but they would be eating better, clothed better, housed more often, and have fewer health risks as a consequence of that. Because a lot of those behaviors come out of not having resources. And this idea that people use these drugs in some kind of mechanical function that prevents them from ever making a reasonable decision just isn't how people experience any of the drugs we use, right? You can have moments, and hopefully none of you have been in the room, but I've certainly been drunk enough where you're like, oh man, this is bad. Like, I don't really know what I'm doing, and maybe I don't remember what's gonna happen, and you know what I mean? I wake up in the morning, what really happened? That happens, right? But the truth is that folks who use drugs on a regular basis, that almost never happens to them, right? And some of that's just the biology of substances, right? So the people in my studies who've been using heroin for 20 years, they actually almost never get high. They're just trying to stay well, right? So they're trying to deal with opiate withdrawal. Okay, the other thing is when you're engaging with people, you can identify things that are other risks that are going on in their environment. And these are just a couple of examples of things that research we've conducted over the years using ethnographic methods and qualitative methods and then quantitative methods to sort of establish patterns of risk behaviors that, again, have less to do with the drugs and more to do with where the activity is happening, right? Or have to do with the economic desperation of the people, right? So one of the big sources, and this first one on the left, is about multi-person use of syringes that sort of comes out of folks not having money. So they have to go in together to buy drugs, and then they've got to split drugs, and then splitting drugs is difficult if you don't have enough syringes, right? So you end up having this sort of risk for HIV and hepatitis C. Okay, so we have these major interventions that have come out of injection drug users. The reason why I was running a needle exchange program in Oakland in the 90s was because the people in my study asked me to help start one. Right? They're like, this is what we need, Ricky, to deal with this problem. And so I was able to help them. And these things have been hugely successful. Similarly, the big talk now is drug consumption sites. We have 2 operating in New York. There's one unsanctioned one operating somewhere in the United States. There's actually 2 at least operating in the United States. And so far they have great results. So people, when they use these sites, they don't die from overdoses. Like when they're in it, they don't die from overdoses. Like I don't know anything that's that effective, right? So, I don't know that we'll have a world in which there's an overdose prevention site for every time someone injects drugs. I imagine that will not happen. But having this as part of the menu of things that we can do to help people really makes sense. And naloxone distribution, a lot of that, there's a lot of talk about giving it to police, which isn't all that helpful. People, there's a push to make it available just over the counter to everyone, which wouldn't be bad. But the key thing is giving free naloxone to people who inject drugs or people who use opiates. That's the most effective method because they're going to be with other people who use opiates, and so then they're able to reverse them. And this is a study from colleagues in San Francisco looking at national data and just sort of beginning to document the impact of this approach, right? 26,000 reversals across the country, right? Now, not every one of those people was going to die, but the data we have about overdose fatalities tells us that about 3,000 to 4,000 were. So this approach literally saves people's lives. Let's skip that. I like to show this because, again, it's that point of when we give people the resources they need, they will use them as intended. So these are basically data from 2 time points in my study. So 2013 is the blue one, and the orange one is 2017, 18. And then the first 3 are Los Angeles data, and the next 3 are San Francisco data. And what you see in both communities is that overdoses went up over time. The numbers of people witnessing overdoses went up over time. And then in Los Angeles and both San Francisco, where there were better efforts to make sure naloxone got into the hands of people who use drugs, there was huge increases in using naloxone to reverse overdoses. And again, not all of those people were going to die, right? But 10 to 15% of them would have. And so you're literally preserving life by making this available to people. Similarly, with the safe injection site, this is data from one of the unsanctioned ones that's operating in the United States. And again, it shows less public injection, no deaths, which is really crucial. They've also looked at things like hospitalization in subsequent studies, and hospitalization goes down. And that makes sense because people go from using drugs in settings that are unsanitary, right? If you're unhoused, you're in a homeless campment, that's not a clean place. They're using drugs in a clean, well-lit place, and so they don't get the bacterial infections that so often happen with people who inject drugs. And so this is just a little schema of the ways that we can use these to sort of deal with the kinds of prominent problems that we have among people who inject drugs. Okay, so we continue to have challenges. It's interesting. So I'm a sociologist who's been working in public health since 1991. And so I've always been a sociologist and thought about these things this way, but now public health has caught up to me. So now we're really crazy about social determinants of health, and people are talking about structural racism and structural violence in ways that we really hadn't been before, which is certainly welcomed. So I'm going to just take you through some of the data from my studies and make a few points about what's happening with the population. So the first thing is, and not surprisingly, because of the way prescription opiates were distributed in our country, the demographics have begun to change about who uses opiates, right? So in our studies, there are more white folks now than there used to be. They're also younger. So for about the first 15 to 20 years that I was doing this work, the age of the people in my studies sort of increased every year like my age did, and now it's going in the other direction. So they're becoming younger than I am. And that's reflected both in their age characteristics and also the time of injection. This is data from Los Angeles where we've collected data over multiple times and looking at changes in homelessness in the population. So when I first started doing this work in 2001 and 2003 in Los Angeles, about a third of my participants were unhoused. Now you see it's much higher. So typically 70 to 80% of folks will be unhoused. And again, that's due less to changes in drug use, although there have been changes in drug use for sure, and more to, the political economy of Los Angeles or the political economy of Santa Cruz, or, all of these coastal cities in the United States are having increased, on the West Coast at least, increased unhousedness. And that's because they're desirable places to live. And so we create unhoused people. And just the statistic we use, or at least I use in Los Angeles is, look, Los Angeles is committed to trying to house people. I mean, we've taxed ourselves, we've expanded bureaucracies to help assist people get into housing. And those efforts aren't as efficient as any of us would like, but they're not ineffective. So each year about 20 to 25,000 people are housed through our efforts to house people in Los Angeles. The problem is we're creating 40,000 new unhoused people every year, right? So it gets 20,000 worse each year, despite the fact that we're building this housing. So, we really have to begin looking at that. And in particular, what my research team and my students, and particularly Jesse Goldshore, is trying to build out is an understanding of how our reflexive response to people being unhoused, and by we, I mean housed people like me, right? Makes it harder for people to get housing, right? So I'm gonna just take you through a series of what I'd like to call uncurl your afro statistics about what's happening with unhoused people who use drugs. So the first thing is people, most of them, are unhoused now. They're often having to move. So 72% of them have to moved in the last 30 days. Now, many of your college students here, so you guys move around a lot, but you move around, in a resource-rich environment for the most part, right? Having to move when you don't have resources is very problematic. The other thing is that a lot of these moves that people have are due to government or security guard stuff, right? So we're actively intervening in their lives in a way that makes it worse. And so to sort of demonstrate this, I took data from my current study, and we've been collecting data since May of last year, so for almost a year, in Los Angeles and Denver, and we sort of broke the group up into three. So there's the housed group, there's an unhoused group that didn't move, and then there's an unhoused group that had to move, right? And that's just one move. And then we began to look at what their characteristics look like from a health perspective. And as this shows you just a simple, crosstab, overdoses are higher, receptive syringe sharing is higher, rush injection is higher, difficulty finding food is higher, difficulty washing is worse, difficulty finding a restroom is worse, right? So we're immiserating them, right? We are, right? The active policies that we support are making their lives worse. It increases exposure to violence, right? I mean, I actually can remember the last time I was hit. I was 18, and I wasn't even hit that hard, right? These folks every day are being threatened, punched, attacked, having their belongings stolen. And then we have this thing about sexual coercion, and the little note below just points out, if you're a woman, transgender person, non-binary person, in the last 3 months, 24% of them have been raped. Look, we're doing this to them, right? These are choices, right? We don't have to make those choices. And then they lose valuable things that they need, right? So people lose clothing, they lose ID. In some cases, the medications, including Suboxone, which is buprenorphine, a medication to treat opiate use disorder, and also Naloxone, right, which is the antidote for reversing overdoses. And so I just put this into a multivariate model just to bring home the point that this combination of immiseration and displacement results in significant health outcomes that are preventable. So more overdoses, more syringe sharing, and it doesn't have to be this way. Again, it's a choice. Okay, so we have that going on. And then on the other hand, and I already mentioned this, so I'll go through this more quickly, is we have things that work, but we won't implement them. And that has to do with that stigma and political will. You know, we see it even with ONDCP, so $30 million, right? That's it for the whole country for harm reduction services. You know, a lot of these programs, you know, they grew a lot in the last 10 years, which is awesome, but you can see geographically and population-wise, there are whole areas that just aren't really covered, where people don't have access to any services. The other thing is, and this is hard for me to say as someone who used to run needle exchange, although mine was a large one, so I feel better about that, which is that, you know, a few programs really do give out most of the syringes. So there's probably 20 that give out 70% of the total syringes at this moment in the country. And those 20 aren't everywhere, right? So Los Angeles does well, San Francisco's awesome, New York is doing well, but there are places that need it that don't do as well. And so people are going to continue to find themselves getting HIV and hepatitis C in those situations. You know, we also run into this issue related to stigma. If you've done any work with this population, you're aware of the fact that people experience stigma throughout the social service and medical process. I have another student, Sid Ganesh, who's really working on looking at trying to implement harm reduction in clinical settings and really getting at the ways in which physicians and nurses and others, you know, maybe not, they're not trying to harm people, but their behaviors are definitely not helping them and creating conditions where people's pain and suffering continue. All right, let me try and speed through this a little bit more. Okay, so we have this new drug use pattern. To be truthful, and I talked about resource humility, I don't really know what to do with this, but I can describe to you at least what's happening and maybe you'll have ideas about what we should do. So, you know, the fentanyl thing has happened, that's killing people, we know that because of the overdose data. But we're also seeing new data, and this is not just, I mean, I see this in my study, a colleague of mine, Alex Kroll in San Francisco has found this, and I just reviewed another paper that found the same thing, which is that people are beginning to transition out of injection and into smoking fentanyl, which is probably good. So it's good because the way they're using fentanyl is, it's a less intensive style of use. So people, not everyone, but enough of them are reporting, you know, you'll take a puff every 30 minutes. So again, you're not getting particularly high, it's keeping you from having opiate withdrawal, and you're probably not going to overdose, right? If you're just doing a little bit every 30 minutes. You know, the problem with that is that we know there are a lot of people who will smoke something, but won't inject it. Right, so the danger is that we may end up with more people using fentanyl than we did when people were just injecting it. So just keep that in mind. You know, and that's a challenging thing, and I don't know what to do about that. So I'm just, I don't have a solution, sorry. Okay, so I think the take home though, at this point in terms of the problems that folks have is that we do need to intervene directly in the social determinants of health for this population. So immiserating them directly interferes with their capacity to help themselves, plus it makes them worse off, right? So we really, you know, we're working on ending the war on drugs, and in places like Los Angeles and San Francisco, people often aren't arrested for simple substance use possession, but they are arrested for being homeless, right? They are arrested or have their things confiscated and thrown away because their encampment is a place the police don't want it to be in. And that harms them. That impedes people's capacity to take care of themselves. The other thing is that we need to try to marry some of the homeless services with these biomedical interventions in the hopes that maybe there'll be better uptake of them since they work so well. Although I don't know that that's happening. What I do know is that we have to stop stigmatizing this population, right? It just doesn't serve any useful purpose. I've talked to literally tens of thousands of people who use drugs over the 30 years of my career. No one didn't not use drugs because someone stigmatized them about it, right? So it doesn't achieve the main goal, which is to stop you from using drugs, right? But it does make people less resistant to getting help because they internalize that stigma and feel bad about themselves, and then that makes it harder for them to help themselves. The other thing is we have to, again, continue to engage the population and use their ideas to help them. And, you know, a lot of this, we see it, you know, we're getting there slowly but surely. So there was a report, for instance, in the LA Times talking about the fact that people who are unhoused don't like living in group housing situations, which completely makes sense to me, right? Like, when's the last time I had to stay in a house with someone I didn't want to? Like, it's probably been 40 years. It's been a long time, right? You know, yet we're asking folks, yeah, you know, you have to live with this person who might have raped you or might have attacked you, right? Or you have to live in this setting where you're really worried about other people around you and they're really worried about other people around them. And so that leads to conflict, right? So, you know, we have to design housing in a way that accommodates the needs that people have. Maybe it's keeping their pets. Maybe it's living with their boyfriend. Maybe it's not living with their boyfriend. Whatever it is, we've got to be patient and we have to open up the options. Because people like options and they sort of need them if you want them to make the next step. I mean, and the same thing has really happened, you know, I don't know what's going on with drug treatment in this country, as an example, but like the fact that it's still hard to get is insane, right? So there's never been a moment in the 30 years I've been doing this work that it's been easier and less expensive to be in drug treatment than it has to continue using drugs. That's never happened. Like, and again, we can fix that. It's not even, this stuff isn't even that expensive, right? We can actually make it really available to people, but we have to listen to them. You know, and some of that involves us as people who aren't unhoused and aren't drug users advocating on their behalf. And so that's sort of what I've tried to do with my research by elevating the meaning in their lives and their experiences to the sort of center of my work. And then pushing for these sort of reasonable changes that are going to make people better, that come out of their lived experiences and their actual circumstances. And we can do this. We've done it time and time again. We should have research agendas that sort of reflect that change. I mean, one of the things that's true, and this is true even of sociologists like me, like I've done a really crappy job of measuring structural racism. Really bad job of it. And what that means is I'm always asking people their race. I'm never asking them about racism. And that's the independent variable, right? There's nothing wrong with Black people. We're every bit as talented and flawed as every other group in this country, right? And so it's not a meaningful variable. Now, when I hear it, I think I'm thinking racism, but when I report it, who knows what people are thinking, right? So if I want to be clear in my scientific communication, I need to measure the things that reflect that. So experiences with discrimination, or educational histories, or what neighborhood did you grow up, or how many times have you been arrested, or all the other things that we know are the operationalization of racism in this society, right? That diminished life opportunities that many African Americans face thanks to residential segregation and our sort of history of white supremacy in this country. So we've got to get better at that, and we have to be more bold in terms of thinking about structural interventions, right? And making that point that, look, we're not going to solve 20 years of heroin use in 2 weeks. That's never going to happen, right? So we have to be patient. We have to design studies that recognize that we're trying to adjust trajectories and opportunities for wellness and not end states. And that there are going to need to be multiple kinds of interventions that happen with people to get to that sort of conclusion where they're doing better. Okay, so, you know, here's my story. You know, we're in a situation where if well-meaning people who've learned about populations don't act, nothing will happen, right? So I'm constantly in 1992 in Oakland, where I know a bunch of people have HIV, and I'm also aware that no one's going to do anything about it, right? And we've seen that happen with overdose deaths. We're seeing it happen with bacterial infections, and you'll hear about it sooner than later, trust me. It's happened with hepatitis C. It's going on with HIV. And so we have to step into the breach and let people know there are solutions to this, and they mostly involve making common cause with people that we spend a lot of time stigmatizing, and then giving them the things they need to succeed. Thank you very much. Yeah,
all right, I think there is a mic out in the audience. And do we have any questions? Oh, all the way over there. Oh, great. I will, oh, the mic is coming at you.
My question is, Doctor, how much do you think that the opioid epidemics, which was so different than previous epidemics because being prescribed by doctors and people getting addicted via the pharmaceutical system first, has impacted our response to COVID? And I'm curious what research is out there in terms of people saying, I'm not going to take a vaccine from the same company that just killed my cousin or has got me addicted to drugs. Like, how do you see that playing out in the research? Thank you.
So I'm going to do my favorite thing, which is say I don't know, because I haven't actually looked at that question. And so having said that, now I will speculate, which is that, I think a through point of all the talks, all the keynotes today, is that our existing economic and political structure will kill you if given the chance. I don't happen to believe that the vaccines are problematic any more so than anything that you give to hundreds of millions of people. You're going to get some weirdness. That's just math, basically. But the two things are definitely connected. I mean, I don't know why everything has to be profitable. And I think as a human, the things that matter to me aren't ever about money, right? I mean, they're my children, they're my wife, they're my community. Those are the things that move me every day. And I think that's true for everyone else, actually. We've kind of tricked ourselves into thinking that unless I'm making a nickel more, somehow my life is going to be unsatisfying. I think there's a lot of deep work to do in terms of changing our political system so that people can feel they can trust it, because they're not wrong. I mean, I think they're wrong about the vaccine, but they're not wrong about Coca-Cola, right? They're not wrong about the food industrial complex, right? They're not wrong about pesticides. So, they weren't wrong about tobacco or vaping even, right? Like, these systems will kill you to make money. The healthcare system does that even, right? I mean, we talk about we have the best healthcare in the world. It's like, well, I have pretty good healthcare, right? But I know if you make less money than I do, and most people do, you have less access to healthcare than I do. And you have longer wait times and less quality physicians at your disposal and less technology. And that's not a bug, that's a feature.
Thank you for that question. We have another one right here.
Hi. So I was an intern at Roots Community Health Center in Oakland, and I did some work with medication assisted treatment for opioid use disorder there. And one of the findings of our research, that I found most interesting, was that there was so much more of a stigma around methadone than Suboxone, because methadone had just been around longer and people had more time to get to really entrench it in stigma. And I was wondering, what are some ways that we can rebrand that kind of medication and start to strip it of the stigma it's been entrenched in?
Well, I mean, some of it is not regulating it so ferociously. I don't know if this is still the case, but like 5 years ago, methadone was the most heavily regulated substance in the country. So I think that would help. So making it normal. I mean, I think we have to change the culture too. And in a sad way, the overdose death epidemic has helped us do that because so many people have lost people. And so you're, given a choice, and, I'll just say the thing I typically say, would I rather someone take methadone than heroin? And that is the authentic choice. That's the practical choice people face. I would say take methadone. Right? And you know what? If you like methadone more than buprenorphine, let's make sure you get methadone instead, right? So there's nothing wrong with giving people what they want or what they perceive themselves to need. We've just made that almost a cult-like belief in our system where, look, rich people, we do all kinds of things to incentivize them. I mean, the thing I can say about myself is I've got all kinds of crazy incentives to behave myself, right? But we don't do that with low-income people. They're always getting punished, often unfairly. And the way we make these medications available is a great example of that.
We'll take one more question. Oh, sorry.
Hi. So this is actually a very timely topic because I just found out this morning that one of my friends back in my home state, that her son, who's a senior in high school, unfortunately died taking opioids, but it was laced with fentanyl. So sorry if I'm a little emotional over that. But they're thinking about using this as a case to change legislation that for drug dealers when it results in a death, because his mother, my friend, puts it at, he was poisoned. She uses those words, not knowing that that's what he was taking. So I'm a little too close to the issue to think about it in a neutral way, but I'm just curious about your thoughts because I very much agree with the harm reduction model. But I'm curious to know about your thoughts on persecuting those that are dealing the drugs.
So first off, I'm so sorry for your loss and the loss of your friend. I mean, as a parent, Mike. So anything happening to a child, your child is the worst thing that can possibly happen. So you have my sympathies. At the end of the day, we want things that work. I lived in Washington, D.C. in 1986 to 1988. And D.C. had about 800,000 people in it at the time. And they were arresting 100,000 people a year, mostly black men and women, because of the crack cocaine epidemic. And those arrests didn't stop the crack cocaine epidemic, and it didn't make anyone's family better, and it didn't lead to treatment for anybody, and it didn't keep someone housed or in a job. And so while I understand the impulse to punish, particularly when there's such a devastating loss, it's not going to solve the problem. And we would all be better off if more people had naloxone, if it was really easy to get treatment when people were ready for it. And I don't know that your friend's son was ready for it, but oftentimes people aren't. But if we make it easier for people to get when they're ready, I think that can make a difference. But further criminalizing it isn't going to stop it from happening. And I am sympathetic to the thought for sure. In Vancouver, which has probably the worst opiate, other than Baltimore, the worst opiate overdose death crisis, and it's been going on for years. Like they're losing 1,000, 1,500 people, 2,000 people every year for like the last 10 years. And you kind of like, when is this going to actually stop? I don't think criminalization gets us there, but I don't know what stops it either. So I just want to say, I think we've tried criminalization and it hasn't worked. So I'm against doing that. I'm for making services easier to get and building out the social infrastructure that I talked about, and I think that will help. But I'm not certain it will, right? Like I don't know what's going to solve it, but I do think day in day out things will be better for people. and particularly that piece around making treatment like absurdly easy to get. You know, drug use is a social behavior. And so as you get more and more people out of the illicit drug market and into either safe supply or into methadone and buprenorphine, you'll change what's going on for the people who continue to use, and many of them will stop using. So, you know, I think we have to sort of think about it a little bit like a diffusion of benefits approach, and then begin changing the calculus about what makes more sense in this moment that I'm feeling withdrawals. So if I can just take methadone right now, maybe I will do that if that's really easy to do. But again, my sympathies, and you know, I do think we just have to keep engaging with people and trying to figure out ways to help. And we do have to stay away from criminalization because you know, we've been doing it 40 years. It's destroyed the African American community. I mean, part of the reason why a third of African Americans are so poor is because of the war on drugs. So I don't think that's the solution.
Thank you so much for your questions. And I want to take a moment to acknowledge the fact that it was noted stigma is a big part of this problem, and us having this venue to talk and have everybody listen opens up that that world for us to learn more and listen. And I want to thank Dr. Bluthenthal for all your knowledge. Thank you so much.
Yeah, my
Let's
pleasure.
give him a
Thank you so
hand.
much for listening.